but we are live and recording, and Corinne, you got the stage.
Hi, good morning. My name is Corinne Kramer. I'm a palliative care social worker here at Aurora St. Luke's in Milwaukee. I'll be moderating this morning's Chalk Talk. I'm happy to introduce Dr. Joe Dixon. He prefers to be called Joe. Joe is completing integrative fellowship at University of Michigan. It is integrative geriatrics and palliative care fellowship. When I called Joe to kind of get to know him just a little bit before this morning's talk, I asked him to tell me about his favorite role model. It was hard for Joe to pick just one, but he eventually picked Father Greg Boyle. He heard Father Boyle present at a during one of his graduation ceremonies, I believe. But he was so inspired and blown away that he this is his favorite role model. Greg Boyle is the director of Homeboy Industries, which is the largest gang intervention and rehabilitation program in the United States. So today, Joe will be presenting on the history of Do Not Resuscitate. So he will be presenting for about 20 minutes. We ask that you hold all comments until he is finished with his presentation. Then please either speak out verbally or place your comments in the comment box below. And without further ado, I'm so happy to present Dr. Joe Dixon.
All right, well, thank you for the introduction, Corinne, and thank you all for having me here today. I think that this is a really cool concept. Congratulations for getting this off the ground, Marty. So my presentation today is going to be looking at CPR and the Do Not Resuscitate order in older adults. We'll take a look at the history and then some kind of modern discussion. So the goals for today, to explore the historical background surrounding the CPR and Do Not Resuscitate order, to check in on recent data, what is the evidence for CPR and the Do Not Resuscitate order in older adults. I'm leaving the A out, attempt resuscitation, just for brevity. And then to apply our knowledge to a clinical case. So we'll start with the clinical case. We have a 77-year-old male with multimorbidity, presenting with what looks like a respiratory infection. Get to know him a little bit, get to know about what's important to him. He's a retired cabinet maker, he's active, swims and runs. You astutely bring up an advance directive and ask him about CPR preferences. And he tells you, yeah, doc, I've seen CPR on TV and they always do great afterwards. My friend had a heart attack in his 50s and lived another 20 years after CPR. What I do know is I don't want to live attached to machines or be a burden on my family. That is no way to live. So based on that, some questions, and we won't answer these now, just to kind of process as we're moving along. Does he have a good understanding of CPR based on his experience with his friend and TV programs he's been watching? What are the chances he will survive CPR? What other undesired outcomes could he experience after CPR? And will a good discussion change his mind, or even should a good discussion change his mind? So to start with a little historical background, I've had fun. I've actually been able to dig into the some primary research on the history of CPR and the Do Not Resuscitate order, and usually go into it at greater length, but given time constraints, I'll keep it on the shorter side. So looking back through time, you see people using their understanding of the natural world, whether spirits and religion or science and technology, being used for resuscitation attempts in some pretty interesting and sometimes entertaining ways. I'm going to jump ahead quite a bit to when CPR was developed for the purpose of this talk, though. So the dawning of the age of modern CPR. Really before CPR was developed in 1960, resuscitation for cardiac arrest was really thoracotomy and cardiac massage. So it was cracking the chest and with your hands actually pumping the heart manually. As you can imagine, probably was not super effective and quite traumatic. To the right here, I have this brief synopsis from this groundbreaking 1960 article published in JAMA that first described CPR. So this is where CPR all began. I just want to highlight here at the bottom, this was a case study looking at 20 patients and within, case series, I would say. And within this case series, they actually highlighted and dug in on 5 patients, describing in greater detail. One really interesting thing to note about this study is if you read the article, 4 of the cases that they're looking at out of these 5 cases that they describe in greater detail, 4 of those were perioperative. And just before going into respiratory arrest, followed by cardiac arrest, they were given very heavy sedatives, often like a big dose of barbiturate. The other of the 5 cases that they were looking at was a 45-year-old who came in VFib, briefly got a round of CPR and was cardioverted. What they say here is that use of this technique on 20 patients has given an overall permanent survival rate of 70%. Just to contextualize that again, 14 out of 20 of the patients that they looked at were alive after 10 months is what they mean there. As you can see at the last sentence there, it's incredibly optimistic. Anyone, anywhere can now initiate cardiac resuscitative procedures. All that is needed are 2 hands. One thing you may kind of take from this is that the patients that are represented in this study, in particular the 5 that they're looking at, these perioperative cases and the 145-year-old in VFib, are not necessarily representative of the sorts of patients that we're typically having these discussions with in the hospital these days. So here are the vital statistics from 1960. And as you can see in all the categories that they're looking at, heart disease was by far the #1 cause of mortality. And I just want to pause here for a second to reflect on the historical moment from the medical perspective. So in 1960, new antibiotics had come on board. Hygiene measures, both greatly in combination, reduced morbidity and mortality in the United States. Life expectancy from the late 1920s to the late 1950s increased 11 years in males and 15 years almost in females. The Salk polio vaccine was developed in 1955. The measles, mumps, and rubella would soon follow. Watson and Crick had described the DNA double helix in 1953. Enormous breakthroughs in treatment and understanding of cancer. Mustard gases were being used. Radiation therapy was initially being used for shrinking tumors. And this was combined with enormous paternalism in medicine. It was cultural dominance of the doctor knows best in medicine at the time. This is all combined with heart disease being the leading cause of death. And now there's this article showing that 70% of people can survive cardiac arrest. So all this is to say that it's not surprising that CPR really took off in this kind of milieu of different things combined together to make CPR this new standard of care and led to its widespread adoption. So jumping ahead just a bit to the development of the Do Not Resuscitate order. It took a full 14 years from 1960 to 1974 until the AMA formally recommended documenting when CPR is considered to be contraindicated in the chart. It took 16 years from 1960 to 1976 until the first hospital policy was published in the New England Journal, coming out of Beth Israel Hospital in Boston. At the time, you had to have a committee. It had to be unanimous among the committee members in order to go ahead with the Do Not Resuscitate order. And there was very strict criteria, which I don't have time to go into all of the details of. A full 30 years until the Patient Self-Determination Act happened in 1990. So this, put some legal might behind the Do Not Resuscitate order. It required that any health institutions that received state funding inform patients of their rights of medical decision-making at the time of admission. And we're seeing that these days. That is carried on to the present day, including their right to reject vital support measures such as CPR. So just to kind of summarize where we are today, bringing up to this point, the first cases of CPR were not necessarily representative of the average CPR recipient of these days. There was this historical and cultural milieu, all these forces that led to its unchecked adoption. In that that cultural background, the historical background, it took many years until the Do Not Resuscitate order was adopted and implemented. So all of this is to say that the Do Not Resuscitate order was not inevitable. We sometimes think of that as this logical counterbalance to CPR that just makes sense. But I think that there's an argument to be made that even despite that feeling today, it took a lot of time and work in order to get the Do Not Resuscitate order adopted. So the second half of my talk is, where are we today? What are the modern outcomes of CPR in older adults? And in older adults in particular for two reasons. First of all, I'm doing a combined fellowship in geriatrics and palliative care. That is, the bulk of the recipients of CPR these days are above 65. And that's really where the best data collection is as well, looking at Medicare data. So inpatient outcomes, there was this large study that came out in the New England Journal in 2009, looking at over 430,000 Medicare patients who received CPR while hospitalized. 18% survived to discharge. So that's a good number to keep in mind. Factors associated with lower odds of survival included being male, the older you were after age 65, chronic disease burden, and then being Black or non-white. Survival rate, interestingly, over the span of time that they looked at this data, from 1992 to 2005, did not change. So essentially, even though hospitals were getting much better at implementing, very strict protocols, they had these code response teams, et cetera, that developed in this time, the survival rate did not change. This is from the same study looking at where people head to after receiving CPR in the hospital. And as you can see that over time, fewer people headed home. More people actually headed to other facilities, including another hospital, skilled nursing facilities, and then that orange line at the bottom, you see hospice kind of ticking up over time as well. This coincided with a decrease a push to decrease the length of hospital stays. So I think that explains some of it, but also likely patients were getting sicker. Looking at outpatient outcomes, this is a really interesting study out of Sweden looking at early CPR in out-of-hospital cardiac arrest. So Sweden is probably, in my estimation, the best place to have a cardiac arrest if you're going to have one. About 3 million people in Sweden are trained in CPR out of a population of 10 million people. They have this rapid alert system, an excellent registry. They're like really on top of CPR in Sweden. And so this is kind of the best place to see what a best case scenario would look like. So in people who received CPR by a bystander before the paramedics arrived, the 30-day survival was just north of 10%. It was worse if you're older. And then if people did not get CPR before EMS arrived, that decreased to 4%, again, less if you're older. There was a study looking at long-term outcomes among elderly survivals of out-of-hospital cardiac arrest, a US multi-center study coming out of the Journal of the American Heart Association in 2016. So these are people who survived, the small amount of people who survived. 1/3 of those survivors died within the first year. In particular, the first month was found to be the most vulnerable to dying. 60% of those, around 60%, were readmitted to the hospital within the first year, and 25% of those patients were readmitted 3 or more times. Functional status, not surprisingly, was a strong predictor of poor outcome. Then there was this interesting study that came out in the Journal of the American Geriatric Society earlier this year in January 2020, looking at older adults 80 years or older, looking at the outcome and perception of appropriateness by clinicians regarding CPR. So it's kind of interesting. It's a multi-center international study looking at groups in the US, Europe, Israel, and Japan. The last attempt of CPR on these patients was felt to be appropriate by over 52% of clinicians. That included physicians, nurses, and often emergency medical technicians, paramedics, etc. Despite this very high feeling that the last attempt for CPR was appropriate in each case, the survival to hospital discharge was quite low, up to 3% at best. Neurological outcomes. There was this GO-FAR study published in JAMA in 2013. The overall rate for survival to discharge with a cerebral performance score. This is of 1. So that means basically no to minor neurological defects. A minor neurological defect, a CPC of 1, would be something to the effect of a minor cranial nerve abnormality, like a mild dysphagia, something like that, was 10.4%. So we go from 18% overall survival to just about 10% survival with good neurological function. Among other factors, again, age was associated with poor neurological outcomes. This was a really interesting study coming out of Germany, looking at, really, the old adults. So these were patients greater than or equal to 90 years old, admitted to the ICU following cardiac arrest in Germany. This is a very small group of patients. Not many people actually even get CPR, let alone survive CPR. And so they looked over a span of 2008 to 2016, a long time span, who achieved return of spontaneous circulation and were admitted to the ICU. Only 48 patients that they found. Over half of those died in the ICU. And I'll just jump to the bottom, that 18% were discharged from the the 1-year survival of these patients was 23%, and favorable neurological outcomes in 55%. The reason I bring in this study is we often think that, you know, people on the oldest end of the spectrum, older than 90 years old, have, you know, really don't have a chance of surviving, especially surviving with neurologically favorable outcomes. But although unlikely, it's not impossible. Collateral damage, this is stuff we all know, but you know, it's interesting to look at the numbers. We all know about rib and sternum fractures, you know, major hemorrhages, airway complications, abdominal injury, serious pulmonary complications that can happen with CPR. I wanted to dive into the influence of education on the preferences for CPR, since this is what we do. We talk about CPR with patients and want to know, is it actually affecting anyone's decision? This is a study actually from 1994 that looked at how does the survival probability affect a patient's preferences for CPR. Was published in the New England Journal. It was based out of Colorado, Denver, Colorado, an outpatient geriatrics clinic. They found that after discussing the patient's probability of surviving CPR, the patients who wanted CPR decreased by half, so from 41% to 22%. Then there was this interesting study in 2015, Journal of Hospital Medicine, looking at randomized controlled trial of CPR and intubation video support tool. They found basically what they did is patients who were 60 years old and above, they would show this CPR and intubation video. Then they randomized the groups into control or intervention group. 64% of the intervention group did not want CPR versus 32% of the control group. My apologies, the control group did not see the video. 60% of the intervention group had a do not resuscitate order attached to their hospitalization versus around 20% of the control group. And then these patients had much higher knowledge scores that they assessed later regarding CPR and intubation as well. So just a summary of where we are today. Inpatient survival around 18% after CPR. Neurologically intact survival around 10%. Although looking at that study in Germany, it's not impossible even for the oldest adults to survive with neurologically favorable outcomes. Outpatient, best case scenario is that you're in Sweden, is going to be about just over 10% at 30 days. If you're 80 years old or older, survival to discharge is around 3% or less in much of the developed world. 1/3 of the people who survive that will die within the first year, and there are frequent readmissions. All outcomes are significantly worse with age. And so just to kind of summarize, CPR does come with physical damage as well. The increased likelihood of loss of function and debility, discharge to nursing home, and dependence on others. So returning to our clinical case, we have the 77-year-old male with multiple chronic conditions. He started to think about CPR. His conception of CPR is based on TV shows and his friends' experience. And he does say that he does not want to live on machines or be a burden to his family. So I will just throw these questions up again. We can discuss these specifically or just get into a general discussion, however is preferred. I'll just stop here for now.
It's Katrina from St. Luke's. I think definitely doesn't have an accurate understanding of what CPR is based on what he's seen on TV, and then his friend's experience at the age of 50 doesn't give him a good portrayal of what it really looks like.
But the challenging thing that we're faced with is how do you kind of combat that, right? Without coming across as though you're challenging the patient. How do you work with them to help them figure out what they actually want?
And one other point too is, even though the survival rate and the likelihood of being able to be discharged and all of those things, even if, so I'm a chaplain, even if he survives a day or two, it gives the family a chance to say goodbye. And so that really comes up. What happens in that space when we know that death is imminent?
Excellent point. We should also not assume that based on the data that we have, that this person will choose one way or the other. They may have a differing opinion, and we should not go in with a specific agenda, more just kind of focusing in on giving an informed discussion, having an informed discussion with the patient and eliciting those values. Yeah, absolutely.
So Rachel has a question for you. She said, I would ask Joe what his approach would be with that case study patient. Is it to provide education about CPR? So.
Yeah, so one of the things I think that came up, and this was pointed out earlier, is that he doesn't really have a great understanding of CPR based on, TV shows. Everybody survives in TV shows, and they're having this lovely discussion at bedside right after CPR. And as we know, that's not the typical course. So I think it is our obligation to have an informed discussion, suss out the patient's values first of all, because if the patient tells you right off the bat that every single beat of my heart is extremely important to me, and I don't care what it looks like, then I think that, we have our answer. I don't think we should necessarily stop right there, but we don't really, we're going to think that probably this patient is going to want CPR, and I don't think it's really even appropriate to push CPR as a real option on a patient who's expressing values that are very different from where we think they might want to go, or where we think that they should go. I'll actually jump to the next slide, because I actually put a little bit in there about what a potential approach would be. There's not only one approach to a patient like this, right? So, as was pointed out, many patients do have incorrect ideas about the likelihood of survival and quality of life after cardiac arrest. I think it's worthwhile talking about that with patients. We saw that when presented, and this is good to know going into these discussions, that when presented with information on the chance of survival, that around 50% will decrease in their preference for CPR. That's just 50%. Many people won't. That's also nice to keep in mind too, because I think a lot of us think that we should really steer somebody towards a particular outcome sometimes. And that's not always the case, or even if it does seem like it is the right thing to do, even with the best discussion, we may not get there. People have very different thresholds for what they're willing to risk. Again, no matter how good the discussion, some people just simply still prefer CPR, and that's okay. Yeah. So some of my recommendations, just generally speaking, and these are, we do this in palliative care, this is what we do, is we elicit values, gave some hints. Clue, I don't want to live life attached on machines or be a burden to my family. Flesh it out a little bit more. Has he seen that? Just kind of work on that one a little bit more. maybe has gone through a particular experience that can talk about and lead you together to, a best decision for a patient like this. I think it's important, rather than just having your agenda is CPR or not CPR. Doesn't want to live on machines. So, it's important to say that, CPR often does come with intubation, and some people are able to get extubated and some people are not. And to walk through him with that more. Ask his understanding of CPR in this case. I think it's an appropriate question to ask more about CPR. What do you think the likelihood that you'll survive are? And clarify those misconceptions. That may or may not change his opinion. And then, once gathered, help determine whether resuscitation attempt is reasonable. So that's kind of where my approach would be, just very broad strokes.
So with COVID, our hospital has now a new unilateral DNR order, which has changed some of the balance of physician autonomy and paternalism and patient autonomy. And that's been a challenge for us, because oftentimes our role in palliative care is to really help further patient autonomy and patient voice and understand their values. But we also recognize that when we're consulted, we're usually consulted because it's the medical team who's having the distress, not usually the patient. And so we get pulled into some of these scenarios sometimes. And I'm curious, at Michigan, do you guys have a unilateral DNR order? And if so, how does your team work with that? And then if not, do you have any sort of opinions about palliative care's role in these unilateral DNR decisions?
Yeah, that's a big question. Thanks a lot.
Yeah, you're welcome.
I mean, you're really highlighting kind of the tension between patient autonomy and beneficence, and really kind of the physician autonomy to be forced into to doing procedures that we think are non-beneficial, right?
Yeah.
There's always that tension there. To answer your question about the policy here at University of Michigan, we do have a unilateral DNR as well. I have personally never seen it used, but I know it does come up from time to time. I know it has been used, and I think it's always really, really difficult when that has to be used. I'm glad that I haven't had to be involved in that yet. I think that's the last thing we want to have to do. Do I think it could be the right thing to do in some cases? Probably. But I think it really deserves a serious discussion, and the stakeholders, including patient's family, the medical team, and ideally spiritual care, bioethics, social work, all of us really putting our heads together and agreeing upon this, because it's not really right to throw that on any one physician or practitioner either. I think there's a place for unilateral DNRs, but it's always, I think, the last resort that anybody wants to have to go to, and we should always try our very best to arrive at an agreed upon destination through other measures.
Ruth, who is with spiritual care, she would like to know, she wants to know what unilateral DNR is.
Sure. So usually a DNR is bilateral or multilateral, in that the patient or the patient's surrogate agrees upon the do not resuscitate order when in event of cardiac arrest, that they would not want resuscitation, and you agree upon it as well. The medical team. So in that case, it's bilateral or multilateral if there are multiple family members involved. Unilateral refers to the patient or the patient's family saying, no, I do want to be resuscitated, and the medical team saying, no, I'm sorry, but in this case here, resuscitation would only harm you and not add any life. And we think that it's, we used to use this term futile. I think it's still thrown around quite a bit, but more, used as non-beneficial now. So I think that if we are called upon, if somebody's asking us to cause physical harm to a patient, what we think is physical harm, sometimes the unilateral do not resuscitate order from the physician or from the practitioner is instituted, saying, look, I do not agree to resuscitate you, to attempt resuscitation because it will not benefit you and could only harm you.
No.
Thank you, Joe. That was wonderful.
Yeah, thanks, Joe.
Yeah, thank you again for having me.
Absolutely.
Thanks, Joe.
Thank you.
All right. Bye.
Great topic. Thank you.
Okay, thank you.
Bye.
Bye.
Bye. Have a wonderful weekend, everybody.